Hello, it's good to be with you again to provide another update on COVID-19 therapeutics. This is the October 2021 update. Here again are my disclosures. Today I'm going to cover 5 topics. I'll talk about 2 small molecule antiviral drugs, Remdesivir and Molnupiravir, which are both RNA-dependent RNA polymerase inhibitors, and 3 different studies on monoclonal antibodies. The combination of BRII-196 and 198, new data on Casirivimab and imdevimab, and data on AZD7442. Most of these data were presented at ID Week, held just a couple of weeks ago here in the United States. The first study is the PINETREE trial, which was an outpatient study of Remdesivir. This study was conducted in high-risk, non-hospitalized individuals with COVID-19 and was a randomized, double-blind, placebo-controlled trial. The study was conducted at 64 sites in the United States, Spain, Denmark, and the United Kingdom, and randomized participants equally between Remdesivir given intravenously 3 times a day with a loading dose of 200 milligrams on day 1, followed by 100 milligrams on days 2 and 3, or placebo for the same 3-day period. There were broad inclusion criteria allowing participants who were aged 12 and over, who had at least 1 risk factor for severe COVID-19, or who were 60 years of age and over to be enrolled. Participants had to have documented SARS-CoV-2 infection within 4 days of enrollment and could not have been symptomatic for more than 7 days. The study enrolled participants from September of 2020 until April of 2021 and was then halted for administrative reasons. The availability of single infusion monoclonal antibodies, as well as increasing vaccine availability, made it harder to find eligible participants. Therefore, only about half of the intended sample size was actually enrolled, with 562 people eventually having received at least 1 dose of study drug and included in this analysis. The primary endpoint was a composite of COVID-19 related hospitalizations or all-cause mortality by day 28, and the percent of participants with adverse events. Secondary endpoints included a composite of COVID-19 medically attended visits or all-cause mortality by day 28, and the time-weighted average of nasopharyngeal virus load from baseline through day 7. This slide shows the primary endpoint. You can see that there was an 87% reduction in COVID-19 hospitalizations or death by day 28. This was a highly statistically significant difference, showing how Remdesivir given for just 3 days to outpatients was really protective against disease progression. There were no deaths in either group by day 28. Despite the impressive clinical efficacy, the virologic endpoint showed no difference in the rate of decline in SARS-CoV-2 RNA collected from nasal swabs. This result suggests that monitoring nasal SARS-CoV-2 RNA is really a poor surrogate for the clinical efficacy of Remdesivir, and is actually quite similar to what was seen in a non-human primate study in which non-human primates experimentally infected by SARS-CoV-2 and then treated with Remdesivir had improvement in lung pathology and reduction in the amount of virus in lung tissue, but no difference in the nasopharynx. Well, another RNA-dependent RNA inhibitor is RNA polymerase inhibitor is Molnupiravir. This is a prodrug of beta-D N4 hydroxycytidine, a cytosine triphosphate analog. This Molnupiravir in its active form competes with the CTP for incorporation into RNA. Its proposed mechanism of action is actually by inducing mutations and therefore preventing viral replication through what is called error catastrophe. An earlier phase 2A study presented at CROI earlier this year showed reduction in infectious virus over 5 days of treatment, as shown in the slide here. The Move Out trial was a phase 3 randomized double-blind control trial of Molnupiravir versus placebo. Eligible participants were non-hospitalized patients with confirmed mild to moderate COVID-19 and at least one risk factor for poor disease outcome, being 60 years or older or having comorbidities, very similar to what we just saw for the outpatient Remdesivir trial, except that the study didn't enroll people as young as 12 years of age. Recruitment was halted by the Independent Data Monitoring Committee after enrollment of 762 participants, where an interim analysis showed a 50% reduction in the risk of hospitalization or death. You can see that whereas 7.3% of participants who received Molnupiravir compared to 14% of those receiving placebo had progression, this achieved a high degree of statistical significance. All we have are these top-line results. There isn't yet a preprint posted on medRxiv or any additional information, but these are nevertheless quite impressive findings and encouraging results for another directly acting antiviral drug. Turning now to the antibodies, the ACTIV-2 study is a large platform study being conducted by the AIDS Clinical Trials Group with sponsorship from the National Institute of Allergy and Infectious Diseases. And this particular component of ACTIV-2 examined the safety and efficacy of a combination of SARS-CoV-2 monoclonal neutralizing antibodies, BRII-196 and BRII-198, in non-hospitalized patients with COVID-19. As I mentioned, this is a seamless phase 2-3 platform trial to evaluate the safety and efficacy of investigational agents, specifically in outpatients with COVID-19. These two antibodies are non-competing anti-SARS-CoV-2 monoclonals, which have modifications in the Fc domain that prolong the half-life of the antibodies by reducing Fc receptor binding. The two antibodies were given in this trial as a one-time sequential intravenous infusion of 1,000 milligrams each, infused over 25 minutes or longer, and were included in a randomized placebo-controlled phase 3 evaluation in this platform trial after graduating to phase 3 from successful phase 2 studies. So between January and July of this year, with nearly half of the enrollment occurring in June and July, just over 800 participants were enrolled at sites in the United States, Brazil, South Africa, Mexico, Argentina, and the Philippines. These were all adults with mild to moderate COVID-19 who had high risk of progression to severe COVID-19. They initially had to be within 10 days of documentation of their infection with no more than 10 days of symptoms. That was later shortened to just 7 days. You can see that participants were randomized equally to receive either an infusion of the two antibodies or a placebo infusion, and then followed for 28 days. This slide shows the cumulative incidence of hospitalization and or death through day 28. There was a nearly 80% reduction in the risk of progressing to the primary endpoint for participants who received the antibody combination. Just 2.4% of those participants had progressed by 28 days compared to just over 11% in the placebo arm. In terms of absolute numbers, that was 12 hospitalizations and a single death in the BRII recipients versus 45 hospitalizations and 9 deaths in the placebo recipients at the time of the DSMB review on August 23rd of this year. Looking at adverse events, there were fewer grade 2 or higher adverse events and fewer severe adverse events in the BRII treated participants compared to the placebo recipients. So that is a really very promising combination, and it has now received emergency use authorization in the United States. Now, a combination of antibodies that we've spoken about on several occasions in this program is that of Casirivimab and imdevimab. And you may recall on a previous program, we discussed data coming from the recovery study that showed that in hospitalized patients, administration of this combination of antibodies to individuals who had not yet developed antibodies against SARS-CoV-2 had a dramatic effect in terms of reduction of mortality. This is different than what had been seen in other studies of inpatients where the antibodies had no benefit. And this is a second study done this time mostly in the United States that had the same result. So here the study design was that hospitalized patients who were adults with symptoms of less than 10 days prior to randomization, SARS-CoV-2 confirmed by either antigen or molecular test within 72 hours of randomization and hospitalized for 72 hours or less, were randomized to receive either 2.4 grams or 8 grams of the REGEN-CoV combination of Casirivimab plus imdevimab. This analysis focuses on two cohorts, those who either were symptomatic but not requiring supplemental oxygen or on low flow oxygen, but they had to be hospitalized. They received their infusion and then were followed for 28 days. They were stratified on the basis of whether or not they received Remdesivir or corticosteroids or both, and also stratified by country. The primary endpoint was all-cause mortality, and this slide shows the results. Very similar to what was seen in the recovery trial, there was a significant reduction in mortality among those who received the combination antibody, and that result was notable in those who were seronegative at entry. So here we see the solid line demonstrates the progression rates among those who received placebo and were seronegative, and the green line shows the recipients who received the combination antibodies who were seronegative, and that green line is quite significantly lower than the black line. Whereas for the seropositives, you see the blue and purple lines are really quite close together. So no benefit in terms of mortality among those who were seropositive at randomization, but a significant benefit for those who were seronegative, confirming the recovery trial result. We look here in this tree plot or forest plot of the data, different endpoints, either a death within 28 days, again, focusing on the seronegatives, we see a highly significant result with a 56% reduction in relative risk. And if we look at discharged alive from hospital, there was about an 11% lower rate of reduction in that risk here. The benefit favors Casirivimab and imdevimab. So you were more likely to be discharged alive, is what I'm trying to say. Likewise, progression to death or mechanical ventilation, there was a 47% reduction in the relative risk for the antibody recipients. And we can see as well on this plot that those benefits were not significant for those individuals who were seropositive at entry. Turning to a different combination of antibodies, and now the AZD7442 antibody combination of tixagevimab and silgavimab. These antibodies get harder and harder to pronounce, this time as pre-exposure prophylaxis of COVID-19 in adults. And this was another study presented at ID Week in late September, early October. So the PROVENT study screened nearly 6,000 participants. They needed to be adults who were 18 years of age or older at increased risk of not responding to SARS-CoV-2 vaccine or having increased risk of infection. They had to be negative by a point of care serology test and unvaccinated at the time of screening. They could not have had prior SARS-CoV-2 infection or a prior result, a positive test result, nor could they have received vaccines in the past, COVID vaccine in the past, or prior antibody treatment. just under 5,200 of the screened participants were ultimately randomized and received either a single dose of 300 milligrams given by 2 intramuscular injections of the AZD7442 antibody combination or placebo. The primary endpoints were an efficacy endpoint, that is the development of symptomatic SARS-CoV-2 positive illness within 6 months after the dose, and a safety endpoint in which adverse events occurring through 15 months after dosing were collected. This slide shows the primary efficacy endpoint, which demonstrated a 77% reduction in developing symptomatic COVID-19 in participants who received the AZD7442 combination antibody compared to placebo. You can see that roughly 1% of the placebo recipients and 0.2% of the antibody recipients developed SARS-CoV-2 infection with symptoms over the course of the clinical trial. Looking at subgroup analyses, and I apologize for the slightly fuzzy appearance of the slide, but similar results were seen in those under age 60 and age 60 and older, in men and in women, across different racial and ethnic groups, here by race and here by ethnicity, presence and absence of COVID-19 comorbidities, whether participants were at high risk for developing severe COVID-19 or not, and whether they were obese or not. So in summary, we have now really several new important studies demonstrating both the new opportunities for treating people with early COVID-19, as well as new ways of preventing acquisition of COVID-19 by those at risk for not responding to a vaccine or who can't be vaccinated for one reason or another. Look forward to the discussion.